Welcome to PodcastRx, a production of Diamond Pharmacy Services. This is a show about pharmacy, but don't let the title fool you. While we definitely talk with pharmacists about medication topics, we also sit down with nurses, technicians, and other pros to discuss relevant issues in corrections health, long-term care, and so much more. Whether you're a pharmacist, a practitioner, or just find these things fascinating, this is a show for you. On this episode...
So we find that anytime there's a transition, whether it be through the care level or the provider, there is that chance of medication safety not being optimal.
How do you optimize medication safety across different care settings, especially in the skilled nursing environment? To get some insight, we talk with Deborah Milito, Pharm. She's the Director of Clinical and Consultant Services for Diamond's Skilled Nursing Division. We discuss how medication reconciliation, drug regimen reviews, the IMPACT Act, and pharmacists themselves all work together to reduce medication errors across different care settings. I'm Adam Campbell, and this is PodcastRx. All right, well, I want to welcome back Deborah Milito to PodcastRx. This is your second official appearance on the podcast, so I'd say it's your third because you were on our educational conferences episode. You were one of several people we had on that time. And the last time that you were on the show, we talked a lot about antibiotic stewardship. That was very much top of mind for you at that time. I know that a couple months after our conversation, or a month or so, you were going to present on it at the ASCAP national meeting. And that year for our educational conferences, you were also talking about it a great deal. Now, this year, your topic is medication safety through transitions of care. That's your topic du jour, so to speak. So as in 2018, 2019, you'll be presenting on it in several venues, the educational conferences, also a couple nursing associations. So how did this topic rise to prominence for you?
Thank you, Adam. Yes, this is a popular topic for a number of reasons. Most notably, the fact that we need to do a good medication reconciliation at the different transitions of care that our patients and or residents go through. And that became a regulation back in October of 2018. So that's really where it all started. And that's sort of the way that we're looking at it, is that it will improve safety if we do a good medication reconciliation at each chance, for each chance that we have as our residents go through different levels of care.
Sure. Now, you mentioned the regulations. We will get into that a little bit later, but just to get right into the, according to Webster's dictionary definitions here, when you're talking transitions of care, what exactly are you referring to?
So truly the movement of a patient and or resident through different care sites, such as hospital to a nursing home, or home to hospital to assisted living, or perhaps to home health care, or even to hospice. It also includes the movement of the residents through different providers. And that could be a specialist, it could be the PCP physician that someone would have. It might be a nurse practitioner. So we find that anytime there's a transition, whether it be through the care level or the provider, there is that chance of medication safety not being optimal.
Understood. Now, for a layperson like me, I've never really thought a lot about this because in my naive mindset, I'm thinking, oh, isn't that just on a chart somewhere? You know, if it was, whether I was the patient or someone I knew was. Clearly that's not the case, as you just explained. There's several, you could say they have it on my chart. Obviously, there's several theys in the process and different transition points. So where do these medication errors happen at these transition points? How often do they happen, and how serious can they be?
So they can happen at any point along the transition of care. So let's take, for an example, a patient that's at home and perhaps has a fall and has to travel to the ER. They realize that there's been a hip fracture and they're going to be in the hospital for a few days. Well, there's a very good chance that that person could be rehabbed at home. So perhaps they're going home, but maybe they have to go to a nursing home because there's no one at home to take care of them. What happens is we might not get the list of medications that they were on at home. We might not get the list of medications that the nurse practitioner decided to change. Or maybe the medications that the orthopedic surgeon orders for that resident, such as an anticoagulant like Lovenox. That's an injectable medication. So how long are they supposed to be on that? There's no cut date put on that. So maybe that resident, that patient ends up being on it for a month, which is, really too long. So it can be the level of the air can be significant or in some cases not significant, but it all depends on where that patient or that resident is in the system.
Just to add some more context to that, your slide from your presentation that you'll be giving at our educational conferences about this topic, that you say an estimated 80% of serious medical errors involve a miscommunication during that transitions between settings, and that 20% of patients transitioning from the hospital they experience an adverse event, and of these, 66% are related to medications. So the stats there, that says a lot.
Yes. And, on my wish list would be, I want to see the medication list of what the patient's on at home. I want to compare it to what they have been on in the hospital. And then I want to see if they're going to a nursing home, what is the nurse inputting into the electronic MAR? And that's where a really good medication reconciliation could actually take place, is if we had those three pieces of information. Unfortunately, we don't always get the medication list from home. And so we just don't know if we're missing anything when they're in the hospital and then they're discharged.
Sure. What's your professional advice to improve that process so that, again, that everything is accounted for in that area?
So wherever a patient goes, whether it's to their PCP or to a specialist, one of the first things that's always asked at the office is, do you have a list of your current medications? So most patients have that information. I just don't think it's being asked for when they go to the hospital, for instance. It's, maybe they write some things down, but we don't have that list. And the other area where I think that could help us is if whatever pharmacy that patient goes to, that they would get a list from the pharmacy, and all they would have to do is just hand it over, and we would be able to compare medications. And where this comes in handy is, like, say, for instance, someone goes to the hospital and they're put on what's called a proton pump inhibitor, like Prelosec or omeprazole. Well, that's something that they were not on at home, but they get put on it in the hospital for a few days for whatever reason, and then they go to the nursing home and they end up being on that for weeks and weeks at a time, where that really could be an unnecessary medication. So that's why it would be really important if we had what meds the patient was on at home to compare, just to see if they weren't on that medication at home, do they really still need to be on it? And that gives us an opportunity for deprescribing, as I'm sure we're going to talk about it at greater length.
It can be as simple as a phone call to the pharmacy or a phone call to somebody at home to get that medication list.
And, a lot of the patients are very savvy about what they take. And, that would be the first place I would go is like, do you have your list of medications? And oftentimes that can be provided. But if not, perhaps a loved one that accompanies them to an appointment would have that information, or the retail pharmacy where they go to get their prescriptions filled.
Now, you mentioned medication reconciliation. That, of course, is essentially the thrust of your presentation. And you define it here that's the process of identifying the most accurate list of all medications that the patient is taking. That's the name, the dosage, the frequency, and the route. And you compare the medical record to the external list of medications, as you just talked about, that's obtained from the patient, hospital, or other provider. So as a consultant pharmacist and someone who also oversees consultant pharmacists, how often are you seeing these type of medication errors, like safety issues, like incomplete reconciliations happening every day? And what kind of factors are driving them, aside from some of that you already mentioned?
Sure. So we oftentimes call these errors, if you will, irregularities. And so we find a very high percentage of irregularities as a senior care pharmacist when we're reviewing the hospital medication discharge list to what they were on in the hospital. And I guess the most common ones that I see are any medication that has a suffix, such as an XR or ER, that sometimes gets missed. I also see orders being put in for routine when they were on as needed or PRN in the hospital, or vice versa. I also see different frequencies, perhaps BID or twice a day in the hospital, but it gets transcribed to 3 times a day at the nursing home. So those are some pretty important ones that we see. We also sometimes see omissions where they were on a medication or medications in the hospital, but it doesn't get transcribed to the nursing home orders.
We need to take a break from the show to talk about something very important: continuing education, specifically for those of you who work in long-term care. You know that working in personal care and assisted living communities and skilled nursing facilities is a career full of rewards and, of course, many challenges. And one of those primary challenges is keeping up with the issues and trends affecting the care of your residents, from the clinical to the regulatory. Diamond Pharmacy Services is proud to help keep the long-term care professionals of Pennsylvania in the know with our annual educational conferences. These events feature continuing education courses on a variety of timely topics affecting the long-term care profession. And the presenters include Diamond's very own pharmacists, nurses, and professionals, along with occasional outside guest speakers. Whether you're a registered nurse or the administrator of a personal care community or a nursing home, you can earn continuing education credit with us. If you're interested in learning more about the Diamond Educational Conferences, we invite you to visit www.diamondpharmacyeducation.com. View current registration and agenda information, speaker biographies, and take a look at past conference photos and video. We'd love to welcome you to a future conference. And now, back to PodcastRx. What are the tools at your disposal to identify any potential high risk or potentially inappropriate medications? And do all these processes classify as medication reconciliation? I assume med reconciliation is a very broad umbrella, and there's lots of ways to do it. So what tools are at your disposal? What do you tend to use the most often to confront that?
So when evaluating the discharge list, in addition to a medication reconciliation, we also do what's called a drug regimen review, or DRR. And DRR and med reconciliation were identified in the Impact Act that started October 1st of 18. And the drug regimen review is something that we've been doing for many years, and it's for every new admit or readmit that comes into any of our facilities. And on that list, on that form, we're looking to see if any medications are on the Beers list. The Beers list is a list of medications that's updated every 3 years, and it basically is looking at the inappropriate use of certain medications in residents over the age of 65. And they are suggestions. They're not etched in stone, but we do use that as a guide pretty often when we're doing a drug regimen review, to let the facility know that this medication is on the Beers list for this reason, and you might want to consider evaluating the continued use of that med.
How is it with being a consultant? Like, how easy is it to have your recommendations like that implemented in these settings?
Well, there is a process, and we are required to review the chart of a nursing home resident every 30 days as per the CMS guidelines. And once we are there for a 30-day visit, we do a very inclusive medication regimen review, or MRR. It's different than a DRR. An MRR is what you do every 30 days. And that's more involved. You have the chart in front of you. You can look at all the labs, you can look at the doctor's orders, the progress notes, nurses' notes. And then what we do is we send our recommendations then to the director of nursing and the medical director, and they sign off on those, and they either agree or not agree. That would be the attending physicians would agree or not agree. And we're always looking to make sure that if they don't agree, that they're listing the clinical rationale as to why they're not agreeing.
Okay. So medication reconciliation, as it's done, very thorough process. And that kind of, you sort of answered the next question I wanted to ask you. That was, is it a standard practice, medication reconciliation, as it's defined? Now, clearly what you just described, that is, the regimen reviews, things like that. But is there any variance in between different facilities as to how the process goes?
Yes. So as a matter of fact, when the Impact Act came out, it simply stated, and maybe not so simply, but that a medication reconciliation had to take place. Unfortunately, it did not say who had to do that. So nurses are doing it, but we feel that as pharmacists at Diamond Pharmacy Services, that we owe it to our clients to do a complete medication reconciliation for every new admit and readmit. So we look at that as a value-added service that we provide. From a professional standpoint, my professional organization, which is the American Society of Consultant Pharmacists, or ASCP, we have written proposals into CMS asking for them to please change that to say that a pharmacist needs to do that. But right now, it doesn't say who has to do it.
Okay. How, just as a side note, how are those lobbying efforts going between?
They're listening.
Yeah.
They have acknowledged what they have received. So that's a good thing.
Definitely. A sort of related question I wanted to ask, looking through your presentation again, one phrase I didn't see in your presentation was medication therapy management. And from my research on this, medication reconciliation is a part of MTM. Is that correct?
Yes, Adam. Medication therapy management, or MTM services, are identified through different insurance carriers. And then that information is given to different MTM companies. So we are alerted to that information, and we do provide MTM services as they are identified through different insurance companies.
Okay. Yeah, that's, I was just curious of the connection between the concepts. It seems like one's part and parcel of it, but now I understand that a little more clearly.
Well, MTM, for some cases, it's simply looking at an adherence issue, whereas some MTM can be very comprehensive, where you're looking at a lot of different disease states and looking at the immunization status of the patient or the resident, and also looking at their diets and if they're smokers, et cetera. So it can become very involved, or it could just be a yes or no question, wondering if the insurance company is wondering if someone's on a statin, for instance, because they meet the criteria.
That's very interesting. Now, this topic, medication safety through transitions of care, it sounds like it's a problem that's as old as modern medicine itself. So what modes of improvement are out there to improve the safety, whether regulations, I think you mentioned a few there, professional society standards, ASCP, et cetera. What's out there, and what do you see professionals like yourself adopting in this area?
Well, from a granular level, we're doing what's called a performance improvement project, or PIP, on the medication reconciliation for each of our facilities. So we're letting them know, hey, we did get the information we need to provide a medication reconciliation, or we did not receive the hospital medication discharge list and we won't be able to complete that. We also look to see if there are any trends in any irregularities that we identify, and we certainly let the facility know if we're seeing, a certain issue come up over and over again.
Thanks Thanks so much for listening to PodcastRx, a production of Diamond Pharmacy Services. While we're taking a break here, we'd love it if you took a moment to follow Diamond on one or more of our social media platforms. On the corporate end, you can follow us on Twitter @DiamondPharm, connect with us on LinkedIn via our Diamond Pharmacy Services company page, and also subscribe to our Diamond Pharmacy Services YouTube channel. Our long-term care division has a Facebook page, and you can find that at facebook.com/DiamondPharmacyLTC. They also have a LinkedIn showcase page. Just search for Diamond Pharmacy Services Long-Term Care Division. If you're a listener in our hometown of Indiana, Pennsylvania, our retail drugstores and medical supply stores also have a social media presence. Find them on Facebook, page name Diamond Drug Stores and Medical Supply, on Instagram @diamonddrug.medsupply, or you can subscribe to the Diamond Drugs YouTube channel. We really appreciate your support of the podcast and would appreciate your likes and follows on these social media channels. Now back to the show.
Getting back with Deborah Milito here on PodcastRx. In your presentation about medication safety through transitions of care, you mentioned PDPM, or patient-driven payment models. For anyone in the skilled nursing area, this is a relatively new development. And so how does this and the IMPACT Act affect medication safety measures? And first, though, if you could give us a refresher on what both of those things are, PDPM and the IMPACT Act, and just how they're affecting skilled nursing facilities right now.
The IMPACT Act started back in October of 2018, and that was where we were informed about the drug regimen reviews and the medication reconciliation that we've covered a little earlier today. Then in around October 1st of 2019, a new reimbursement system came to be, and that was called the Patient-Driven Payment Model, or PDPM. And one component of that model for reimbursement to the nursing homes is making sure that the appropriate diagnoses are present for the different medications. It will help with some reimbursement issues. And the example that I've seen myself that I wanted to share is, let's say, for instance, someone is on fluconazole or diflucan, and one nurse to another says, why are they on that diflucan? And the nurse at the hospital says, I think it was for a UTI, or urinary tract infection. So that's carried over to the nursing home. And since PDPM is in force now, what's missed there is that it really wasn't for a UTI. It was for an esophageal candidiasis. And that's a much more serious type of infection, where it can even be called an opportunistic infection, which you get points for that under the PDPM model, and you get a higher reimbursement. So I think that it kind of all goes together. Medication reconciliation, a drug regimen review, looking for appropriate diagnoses for PDPM. It all helps to prevent medication errors or irregularities or the use of unnecessary medications.
Sure. Those measures are essentially forcing that a little more, making it more standard, more mandated.
Yes.
Now, you also, in looking through your presentation, I see antibiotic stewardship in there, which, big surprise if anyone who's listened to our conversations with you before, and medication deprescribing. You did touch on those a little bit, and we know that those could be their own podcast topics, and they probably will at some point. But again, if you could just talk through how these fit in.
With the antimicrobial stewardship, we've had to have that in place now for several years under the CMS Mega Rule Phase 2. And that's where we were looking for appropriate diagnoses for all antimicrobial orders, along with discontinuation dates. So we really want to decrease resistance and reduce adverse effects to the unnecessary duration of an antimicrobial. So that's where we're at with the antimicrobial stewardship. And as that relates to PDPM, we're looking to see when we can switch an IV antimicrobial to the oral or PO route. And oftentimes after 3 days, if the clinical picture is looking pretty good, a senior care pharmacist could make the recommendation to decrease that to or to change it to the oral route. And that's better quality of life for the resident, usually lesser fees associated with that, and less chance of infection because you have the IV line that's been removed.
Understood. Now, these medication safety measures, now you've mentioned the different ways in which they're being put into practice each day. What's the great big impact that you're seeing across the board? If you could give a view from 50,000 feet with these new things in place, how does it look as it did 10 versus 15, 20 years ago? And as I know you've been practicing that long, but.
Well, I think the bottom line is that our goal should always be the best care for our resident. And with all of this in place, I think it provides a higher level of care and just more attention to detail in taking care of our residents.
Sure.
So better outcomes, more positive outcomes.
You're spending a lot of time at the facilities as a consultant, of course. And so are you getting a lot more questions from staff? And just how are you generally educating staff about these things?
Yes, so I do a monthly medication management note that goes to all the directors of nursing, as well as an antimicrobial stewardship note that goes to the director of nursing, the medical director, the infection preventionist, and the nursing home administrator. And those two notes are always about a timely topic. So, for instance, we looked at the diagnoses of direct orally acting anticoagulants, or DOACs. And we found that oftentimes just the word anticoagulant was being inserted as a diagnosis, which that's not a diagnosis. That is a class of meds. Sure. And so we've been working really hard educating the staff, not just the nursing staff, but the medical staff as well, about how the appropriate diagnoses of DOACs are so important. And the reason for that is based on the diagnosis of, say, Eliquis, the dose would be different depending on the diagnosis. So the dose for atrial fibrillation versus venous thrombus prophylaxis is different. So if we don't have the appropriate diagnoses, we can't recommend the appropriate dose.
I think that really ties into the last thing I wanted to ask you, which there's been a general expansion of the pharmacist's role in the healthcare team in terms of practicality and prominence. Is that perhaps the biggest step we got to take here, is just involving pharmacists more in the whole process, or is it more complex than that?
I think that the team approach is the best approach, and the pharmacist needs to be part of that team. And I think that has improved tremendously over the last couple years. What we would ultimately like to see is for CMS to recognize us as providers. And if we had provider status, perhaps that would improve the process even more. But that's okay. We've been working very hard in some states. There is some provider status, and we feel like there's some momentum. So we just want to keep it going, but we just want to be part of the team.
Absolutely. Well, part of the team, and of course, we're always happy for you to be part of our podcast. So, Deb, thank you very much for talking about this with us today.
My pleasure.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Find new episodes of the show on SoundCloud, Stitcher, and Google Play. And please subscribe, share, and leave us a review.
Music in this episode by Wolfgang Worley. Sound Express by Getty Images. Additional music by the 126ers and Silent Partner.